Everybody hear me? Those that want to? Okay. No, there's nothing too controversial here, don't worry. So I'll save that for Trevor. Anyway, my name is John McIlveen. I work for the Oregon Health Authority Health Systems Division in Salem, and I work in our unit, Addiction Treatment Prevention and Recovery Unit, that deals with the substance abuse treatment system in the state. Everything from contracts to program management. My specific role is as the State Opioid Treatment Authority for the state of Oregon. So I have a few different activities I do in that role. The primary role of any State Opioid Treatment Authority, the SOTA for short, that's the acronym, is to help manage and regulate the system of state and federally licensed opioid treatment programs in each individual state and territory, commonwealth, whatever the case may be. So these are facilities. I'm talking to a pretty experienced crowd here in this field, I think. Opioid treatment programs are programs, comprehensive programs that offer both counseling as well as dispense full and partial opioid agonists for the treatment of opioid use disorder. We have 18 out of the 19 in Oregon are both state and federally licensed. So anyway, I work with them very closely and also serve as kind of a liaison between them and our state offices and our regular licensing and certification department, as well as the SAMHSA CSAT, Division of Pharmacological Therapies, that manages and the rules and regulations around the dispensing of medication. And finally, the Drug Enforcement Administration, United States DEA, that manages the dispensing of the actual medications, which are with methadone, obviously Schedule II. I also deal with a lot of other issues in the division. I principal investigator on a couple grants, our medication-assisted treatment prescription drug opioid addiction grant. And I wanted to talk about this. I mentioned to someone a few minutes ago. That's really not, I'm going to talk about a couple of those things that the title is, but it's an old title, and I forgot to take it off. So, but it looks good, right? So anyway. So I managed some federal grants. Involved also so I'm principal investigator on that grant I mentioned. I'm also involved in the state targeted response and the state opioid response grants as the subject matter expert, and deal with a lot of other issues related to opioid use and misuse, especially as it focuses on treatment and recovery issues. So jumping forward, what I want to do, but before I do that, and I know Jude, I only have a few minutes, I guess, but so I'll go through this pretty quickly. A couple different things. I wanted to give you kind of a quick brief overview of some of the things that we're dealing with in terms of opioids around the state, what that looks like, again, from sort of a treatment recovery standpoint, talk a little bit about some of the expansion. I also want to highlight, had the opportunity that's related to the subject matter today to moderate a presentation, which was an environmental scan of Hep C in the OTP setting. That could be a whole half an hour presentation to show you the results of that, and I'm happy to share that with people as you know, after the presentation or at some point during the day today. But share with you what some of the thoughts were on the barriers and the like, which I think might be kind of an interesting thing for you to take a look at. So there's a little background. I mentioned the opioid treatment program system in our state. Again, that's an editing issue. It's about 9,500 to about 10,000 folks in treatment at opioid treatment facilities throughout the state. Dr. Corthes talked a little bit about buprenorphine and availability around the state. There's a couple facts. I won't go through each one in detail, but we've had a lot of growth in the availability of people to prescribe in an office-based and other environments and settings. Partial agonists, i.e. buprenorphine for the treatment of OUD. As you can see, from in about a 2.5 year period, it's almost doubled, which is fantastic. We still need more of these folks to engage in the treatment. It's a difficult population. One point related back directly to get into the HCV topic is national estimates for the amount of people within the opioid treatment program, not office-based settings, but opioid treatment programs that actually have HCV range, and this is all depending on geography, demographics, socioeconomics, the income levels, every kind of factor you can imagine that goes into a population plays into this, but you're looking at the low end 35 to 40% and on the high end 75 to 80%. So I say to people, I'm not quite sure if you're going to find another setting where you have that prevalence of HCV within a particular healthcare population. If there is, I don't know what it is, but it's pretty high. We, again, license those on a state level, and the federal government, we don't license buprenorphine providers, and that's something that I think is interesting for folks. A couple quick things about, this is specific to heroin, right? I know we talk about HCV and the relationship between injection drug use, which can also be methamphetamine, but in terms of opioid use disorder, some of you in this room, I think, have seen some of these numbers that I presented. You know, in the last 10 to 12, 13 years, 400% increase in the diagnoses of opioid use disorder, which of course changed to a spectrum-based condition after DSM-5 changes, as opposed to drug abuse and drug dependence. Many of you know that. Wide ranges, I kind of mentioned, you know, eastern, northeastern Oregon in particular, very, very high rates of OUD. So it varies throughout the states. Some of the hot spots are northeastern Oregon, coastal Oregon. With the emphasis on rural communities, we have obviously a tremendous problem with drug use and consequently infectious disease in metropolitan areas. But there is a disproportionate impact this is having in rural areas, kind of like was spoken about Douglas County and the like with the HOPE project. Number of seizures increasing tenfold over the last 10 years. Increased prevalence within the criminal justice system. And self-reported use of heroin at intake. And yes, trying to go along with a little technological snafu. But those were kind of the facts. Here's a map of the opioid treatment programs in Oregon. There's a couple that are missing here. Through some of those federal grants that I've talked about, we've expanded access to treatment to a lot of other areas that haven't been previously had access to care. We have a new one in Umatilla County opening, and also one has already opened in Coos. And we have a couple areas also that we're working with some folks for the potential of expansion. If I had my other slide that somehow disappeared, I would tell you that, and again, these are things that you guys know, I think. The highest increase in HCV cases are people who inject drugs in the younger demographic nationally, and that's what we're seeing. And these are a lot of folks that we're seeing in the opioid treatment programs. The prevalence, and I can say anecdotally as well as from, you know, part of my job as my regulator hat, part of my job is actually going through patient files and examining them. And I can tell you that it's rare when I find someone who doesn't have hepatitis C. So it's pretty prevalent. So anyway, that's just, I wanted to show you that. Let me see, there's another map that I wanted to show you guys.
When is the Umatilla site opening, John?
The new year. Hopefully somewhere around first couple weeks of January. So yeah, and that's been partially funded with our opioid state targeted response grant. So yeah, we're really looking forward to that. You know, the idea of all of this is to kind of create a continuum of care. Everyone doesn't necessarily need the level of services that are available at the opioid treatment program, but they need to be available. I liken it to matching treatment with the spectrum disorder that drug use and specifically opioid use disorder has become in the last several years, or is, you know, empirically shown to be, you know, mild, moderate, severe, right? Just like any other medical condition, talk about it as a chronic condition. Some of these maps we actually did, and some people in the room that helped work on these with me for a report that I think is interesting if you guys would like to read, which is available online, which was mandated by House Bill 4143, which is a report kind of state of the state of addiction treatment in the state, so that's of interest. The actual OTPs themselves, we have 19 total. 18 of them have state and federal licenses. The only one that doesn't is right up the hill here at the VA, which doesn't need to have one. So, which doesn't need to have a state license, obviously, because it's on federal property. Couple quick points, though, to move into the HCV issue. Again, I had the opportunity to moderate a conversation with a professor from the University of Missouri at Kansas City working with the Mid-America ATTC. There's been a new emphasis, it's not a new emphasis, but a renewed emphasis on the role of infectious disease, and particularly Hep C, within the OTP setting. So what they did was they brought together a group of thought leaders, including OTP managers, directors, companies. One thing that's going to put what I'm about to say into context is these facilities are run, managed in a variety of different ways. They have to follow the same state and federal standards, right? But many of them have different management structures, different ownership structures. I'll give you an example. We have about 6 or 7 that are owned by a very, very large literally multinational conglomerate of treatment centers and other healthcare facilities. We have some that are kind of your very small, like kind of mom and pop type stuff where people have been doing that work for 20, 30, 40, even 50 years actually. Since methadone treatment in the OTP actually became fully federally regulated and legal. Then you have people kind of in the middle, some private folks that have a few different smaller facilities. Then you have some nonprofits. We have one large one here in Portland, CODA. And then also Lane County and Marion County actually have county-run programs. So why do I mention that that's important? The number one in that environmental scan I talked about of HCV and Hep C treatment and just addressing the issue of it in the OTP varied greatly in this kind of environmental scan that they did, depending on the management, the ownership structure of the facility itself. There was a much stronger emphasis on education and referral and access to care and treatment in the publicly run facilities. So I'm not trying to disparage any privately run OTPs, but there's very much a difference there, and I think that in a short time should kind of help to promote some discussion around that and ways to kind of bridge that gap. There's a lot of very interesting things that came out of it. Things like the program directors, their age, actually had had a little bit of correlation with the amount of HCV education they gave. Who knows? There's all kinds of interesting things. I can pass it on to Judah or the group. It's a really good read. But again, what were the barriers? Reimbursement. A lot of folks in OTPs were really not unwilling to broach the issue of infectious disease with their clientele because it's so common, but to fully kind of jump into the pool and address it in terms of treatment is difficult when the parameters around things like reimbursement and payment for services are unclear. Virtually everybody either offers it, does it, or refers out to it. There's a requirement in our Oregon administrative rules that you do an infectious disease, I'm forgetting the word that we use for it, evaluation.
It's an infectious disease
Screening.
HIV
Mm-hmm. No.
HIV is not, it's syphilis and TB.
I think you're mixing things up. You're required to test for syphilis and TB in the OTP setting. No, but you are required to do an infectious disease screening and evaluation. Right. Assessment.
Whether or not they need it, right?
As to, excuse me?
Isn't it whether or not they need one and then you refer them out? I'm just trying, because having asked, that's kind of what people have been told. So you'll go in, you'll get, they'll do an assessment, you do the intake.
As part of your medical
Right.
history, because you're getting a narcotic as treatment.
The blood draws.
Uh-huh.
Or they'll send you somewhere, but you don't necessarily have to get an HIV or Hep C screen.
Right. Federal regulations and state regulations require that you are tested for both syphilis and TB with your entrance into an opioid treatment program. In addition, our facilities are required to do an infectious disease screening. They're not required to test for Hep C, but the vast majority of them will refer out to specific places for that to be done, but they do an assessment.
Right.
So I guess the bottom line is, and I'll just take questions from now on, is there's a great opportunity here, and you and I have talked about that. That's great. Wow, I read your mind. Fantastic. Whoever.
I was just wondering, of the 120,
820.
Sorry, how do they map out onto this map? Are they all over along the same I-5 corridor, or are they expanding out people?
That's a great question. And I have a map that shows that. This is just I know that the text on this is poor for a huge, big screen, but Green is good, red is less good. Sorry, that's to summarize. So that's per capita by 10,000 person population, the waivers, and that was updated for 2018. So bottom line, what's the summary in a short amount of time? Lots of improvement, lots more access to care, lots more availability, really poor engagement numbers, but they've gone up. Some people, including some people in this room, like Dr. Kortheis and his team at OHSU, have done a great job at expanding access to education, and case consultation for folks that want to get involved in addiction medicine in general, specifically treatment of people with OUD with partial agonists, which has helped at this. I know that it has, because we've had that great increase, but we still have huge areas of gaps. And even in places where we have providers, we've had today it looks better than it ever has, because about 57% of folks who have a waiver have written a script in the last year. But that still leaves 42 that haven't at all, 42%. So when we're talking about 800 people, that's what, math in your head, I mean, that's 400, 300 something people. That's a lot of people. I don't think you have any other, I don't know, medical specialty certification that so many people have that don't use. I don't know, I can't think of one. I mean, I don't know if anybody else can. But so that's important to know. But that's gone up from like 26% 3 years ago. So that's a huge improvement. So,
what is going on? Is there anything being done to change the required screenings? I mean, it's great that we're screening on the TV. It's counterintuitive that everybody's seeing HIV and not being prioritized.
mm-hmm.
Is there something going on? I know it's a federal thing, but
Yes, it is.
statewide.
I think a few different things have and I've, on a lot of issues, even way beyond infectious disease, I've personally worked with my colleagues in public health, many of you that are here today, on different opioid use-related and drug-related issues, and I think this is one that we're going to have to address. As I said before, what are like the biggest barriers? Reimbursement, funding. I think there's going to be some changes around those things, which I think might make it easier to make some of those structural, and when I say structural, I'm kind of more referring to rule change and the like to do those things. One thing that's really important to remember, I think, is that these are busy places dealing with an extremely vulnerable population that's very in need, right? It's time consuming. I don't have time. I could speak for 20 minutes about why the particular OUD population is one of the more difficult populations among the SUD population to address. And it has to do with repeated use of opioids, lack of emotional and regulation, stress tolerance, all kinds of things that you see to a vastly greater degree in this SUD population than you see in most other ones. So they work very hard and they have a lot of work to do. I think part of our job, mine and hopefully some others, is to try to look at ways we can make it easier for them to adapt those things into their current treatment milieu, if that makes sense. Because of course, if you ask, does it make sense? Of course it makes sense. If 50% of the people in your population that you're treating for something have this clear and potentially fatal condition, then it should be addressed, right? It would be in any other medical setting, right?